Dr. Ken Landau. Thanks for watching. Let's talk about miscarriage. Miscarriage used to be referred to as spontaneous abortion. Spontaneous abortion to differentiate it from therapeutic or induced abortion. But the term abortion is a loaded term, and it's got some emotional baggage, some legal issues attached to it. So about 1995, the term miscarriage was used instead. Now, some people have gone a little bit further and they refer to it as early pregnancy loss. But in any event, miscarriage is a failure of the intrauterine pregnancy that ends before 20 weeks after the last menstrual period. After this time period, death of the fetus is referred to as a stillbirth. Now, miscarriage is a natural death of the embryo or the fetus that occurs prior to the time it's able to survive independently. And this happens to be the most common complication of early pregnancy. But we have an issue because there's not a defined time period when we differentiate miscarriage from stillbirth. So in the United States, it's clearly 20 weeks. Australia, it's 20 weeks. On the other hand, in Norway, it's 16 weeks. In England, it's 24 weeks. In Italy and in Spain, it's 26 weeks. And then we have another issue. Women who know they're pregnant have a miscarriage rate of about 10 to 20%. But if we look at all fertilizations combined, we find that the miscarriage rate is well north of 50 or 60 or 70%. That's right. That means that the overwhelming majority of fertilized eggs of women who are technically pregnant, they're not going to go on and give birth. The minority of pregnancies, the minority of fertilized eggs, are going to grow into full-term deliveries. What happens in between? Well, the egg and the sperm combine in the fallopian tube. Woman doesn't know that she's pregnant. Woman certainly hasn't missed her period. Now we can get something known as pre-implantation failure. This occurs in about 30% of all fertilizations. That's a loss of the fertilized egg already between the time it's in the fallopian tube to the time it gets to the uterus before it can implant. And then we have another 30% failure rate that's post-implantation. So post-implantation, it's now implanted in the wall of the uterus and it still fails. So we're up to the majority of fertilizations already, the majority of conceptions already have failed before the woman even knows she's pregnant. And then we have another 10 to 20% where miscarriage occurs when the woman tends to know, but not all women know that they are pregnant even when they have a clinical miscarriage. And then we have the age factor. So the likelihood of miscarriage increases as a woman grows beyond age 30. So the likelihood of a miscarriage in 20, 30-year-old women, about 15% on average. By the time women get to be about 35, it's 20+%. By the time they're 40, it's about 40%. By the time they're 45, it's in excess of 80%. Now, if we look at all miscarriages, about 80% of them are going to occur in the first 12 weeks. And as a matter of fact, the first 7 weeks is the most critical time. After that, then the rate slowly decreases to reach nadir at around age 14 to 20 weeks of gestation. And some people further divide the pregnancy loss into early clinical pregnancy loss less than 12 weeks or late clinical pregnancy loss between 12 and 21 weeks of gestation. But some terms need to be defined. So we have a biochemical loss. This is a loss before the woman even knows that she's pregnant. And she'll never know that she was pregnant. If we were to do some blood tests, we could find out. But usually these losses occur before 6 weeks. We have threatened miscarriage. That's any bleeding that occurs during pregnancy, oftentimes without other signs of problems. The cervix is closed. Woman is otherwise healthy, but she's got some bleeding. We have inevitable miscarriage. That's where the cervix is open. We have bleeding and cramping. We have complete miscarriage. That's when they have all of the contents of the conception have been expelled. Usually, again, that's before 12 weeks of gestation. Afterward, there's some bleeding and some cramping, but spontaneous resolution and the cervix is closed. On the other hand, we can have incomplete miscarriage. This is where some of the products of conception are actually retained in the uterus. The cervix is open, the bleeding can be heavy. Have a significant issue with this kind of condition. We can also have a miscarriage where the fetus or the embryo has perished, but the miscarriage has not yet occurred. And sometimes when some of the products of conception remain inside, then we can have a septic abortion. This is with the incomplete or the missed miscarriage. And then, unfortunately, the woman can become septic. We can have recurrent miscarriage. Recurrent miscarriage occurs when we have recurrent multiple consecutive pregnancy losses in a normal population. If we assume that the clinical miscarriage rate is about 15%, average of 10 to 20%, then we can say 2 miscarriages in a row are going to occur somewhere between about 2 to 5% of pregnancies. And we can say we have 3 consecutive miscarriages on the order of about 0.3%. But that number depends on the age of the woman. So in women who are less than 25 years of age, it's about 0.1%, but it rises by about 100-fold to 13% in women who are over 40 years old. That's 3 consecutive pregnancy losses. But even women who have 2 consecutive miscarriages, they typically are going to be able to carry a normal pregnancy subsequently all the way to term. Now, there's another issue. Sometimes the pregnancy can be what we know as anembryonic. That means we have an empty sac. We have the gestational sac, but we don't have any embryo. That's 50% of all miscarriages. Then we have the other 50% are embryonic miscarriages. This occurs when you have the gestational sac and you have the embryo growing, but the embryo doesn't necessarily get very far. Half of these situations are due to aneuploidy. Aneuploidy is an abnormal number of chromosomes, typically 3 chromosomes instead of the normal 2 chromosomes. Now, the symptoms of miscarriage vary from women to women. Oftentimes, it's a chain of events. It occurs over several days to a week or 2 weeks or even longer. We have either mild or moderate or even heavy bleeding. It could be similar to or heavier than a normal period. During this time, if a woman knows she's pregnant and she's going through a miscarriage, she ought to use a pad rather than a tampon. The bleeding can be, as I mentioned, light to heavy. It could be constant or irregular. It's usually the first sign of an abnormality. People refer to any bleeding that occurs during a known pregnancy as a threatened abortion, but 50% of the time, women are going to go on and deliver normal, healthy newborns. But a miscarriage occurs when the woman starts to pass clots and pass other material, typically associated with uterine cramping, abdominal pain, low back pain, pelvic pain. Complications can be psychological or they can be medical, especially with regard to the infection. What are the risk factors for miscarriage? Older age obviously is one, previous miscarriage obviously is another, but then either the woman or the father smoking cigarettes, more than 10 cigarettes a day, increases the risk. Obesity increases the risk. Uncontrolled diabetes, infection of the reproductive tract, thyroid abnormalities, endocrine abnormalities other than the thyroid. Using drugs, either legal or illegal, is an issue. Drinking alcohol may cause miscarriage. If a woman drinks between 2 drinks and 4 drinks a week, not a day, but a week, that increases the risk by about 70%. More than 4 drinks a week increases the likelihood of miscarriage by about 3-fold. Oftentimes we have an abnormality of the uterus, a congenital abnormality of the uterus that can be corrected oftentimes. That leads to a significant issue, or an autoimmune condition where the woman reacts against the fetus, because after all, the fetus is foreign tissue, and just like you can't transplant foreign tissue in without some sort of medicine, to prevent rejection, we have the same sort of an issue that may occur in some women in their pregnancies, fever and genetic abnormalities, obviously other issues. Obesity can be a significant problem associated with miscarriages or recurrent miscarriages or even subfertility. Caffeine tends not to be an issue. So even if you drink more than 10 cups of coffee a day, you get about 1,000 milligrams of caffeine. That increases the risk of miscarriage only by about 50%. But if you have 2 to 4 drinks a week of alcohol, that increases the risk even more at 70%. Poorly controlled diabetes is an issue, but not well-controlled diabetes. Food poisoning can be an issue. Listeria or salmonella, or from the cat you can get some toxoplasma. Or you could have other infections. You could have CMV, cytomegalovirus, or group V strep, or rubella, or chlamydia infection. Thyroid abnormalities due to iodine deficiency, not typical in the United States. We'll talk about some other thyroid issues later. Exposure to ionizing radiation, or even if the woman had cancer while she was a child, received some chemotherapy, that may have lingering effects and increase the risk of miscarriage. And so too is what's known as a luteal phase defect. If there's not enough progesterone being driven by the corpus luteum, if there's not enough progesterone, then the lining of the uterus might not be prepared to accept the fertilized egg. Intercurrent diseases or medicines like Accutane or methotrexate, or people question about the statin drugs for bringing down the cholesterol. Or there's an ulcer pill that's actually used to cause miscarriages, misoprostol. And then there's a question about some of those selective serotonin reuptake inhibitors that you might take for depression. And while amniocentesis or chorionic villus sampling might be okay in the second trimester, it can lead to miscarriage in the first trimester. And we all agree that exposure to a variety of chemicals may be harmful. Exactly how harmful we don't really know, but exposure to DDT or lead or formaldehyde or arsenic or benzene or ethylene oxide, all potentially harmful. But we know that cosmetologists are exposed to a significant number of chemicals and they don't have any increased risk. On the other hand, women who work in dental offices where there's nitrous oxide being used without scavenging equipment seem to have an increased incidence. Women who have peculiar work shifts tend to have a greater incidence of miscarriage. On the other hand, women who have morning sickness seem to be protected from miscarriage. Now, uterine abnormalities, structural abnormalities of the uterus, occur in about 5 or 6% of unselected pregnancies, but in women who have 2 or 3 or more miscarriages, then we find that there's about a 15% incidence of abnormalities of the uterus. We call them didelphic uterus or bicornuate uterus or arcuate uterus or septate uterus, where we have some extra tissue. We can have duplication of the uterus, duplication of the cervix, duplication of the corpus of the uterus. And by some simple procedures, we can snip some of the septae inside, and that can lead to the incidence of miscarriage going from 40 or 50% all the way back down to the normal level, less than 20%. Now, a woman may develop some fibroids or some other abnormalities of the uterus. That's much less of an issue. Cervical incompetence, not an issue for first trimester miscarriages. Chromosomal abnormalities, we've already mentioned that half of all embryonic pregnancies are associated with issues especially common in older women and older men. So even if the woman is relatively young and the man happens to be old, that means that there's an increased incidence of an autosomal trisomy, where we have 3 of a chromosome instead of 2 chromosomes. That would be like Down syndrome. That's a relatively common issue. Now, the question is, where does the abnormality in trisomy occur? Is it from the male side or is it from the female side? And the answer is, it appears to be from the egg side. So it's the egg in women and the egg, when it goes through the process of meiosis, when there's an abnormality in that process, that leads to the extra chromosome. So when we check the mother, when we check the father for their genes, we don't find any abnormality. It's just the egg happened to have an abnormality. Well, it's interesting that if we look overall at parents who have, or people who would like to be parents, if we look at their genes, the likelihood of abnormalities that would give rise to significant problems in pregnancy is relatively low. But another factor that we have to consider is autoimmunity, where there's a reaction of the mother's tissue against the fetus. Now, some women tend to just make antibodies. Some women tend to be hypersensitive. They make antibodies to their own tissue. The celiac disease that we talk about, the anti-transglutaminase antibodies, or the anti-thyroid antibodies, or the anti-nuclear antibodies, or the anti-phospholipid antibodies. And for the most part, those antibodies tend not to be the cause of problems with miscarriage. They just tend to mark women as being at increased risk for developing the rejection of tissue. On the other hand, with some of what we call thrombophilias. Thrombophilia is a tendency to form blood clots. And we have the inherited thrombophilias where we have antibodies to the phospholipid antibody. Those women seem to have an increased incidence of miscarriage directly because of that antibody, because we get the clot in the placenta, and that destroys the ability of the embryo or the fetus to get nutrition. Now, we have some hereditary thrombophilias. These are protein C deficiency, protein S deficiency, factor V Leiden deficiency. They tend not really to be much of an issue. The issue happens to be the antiphospholipid antibody syndrome. And we can make that diagnosis. And the question is, can we treat it successfully? Well, people have tried the intravenous immune globulins and the prednisone and a variety of other medicines, but those therapies haven't really been subject to rigorous scientific thought and evaluation. But we do know that using heparin, either unfractionated or preferably the low molecular weight heparin, certainly seems to reduce the incidence of the infarctions and seems to be associated with more successful pregnancies. Now, as far as endocrine abnormalities are concerned, some women develop what we call silent hypothyroidism. So in silent hypothyroidism, the thyroid hormone is normal, but the TSH that drives the production of the thyroid hormone might be elevated. Well, if it's a little bit elevated, then probably no therapy is necessary and it doesn't change the outcome. But if it's elevated to more than 4 or 5, the TSH elevated to more than 4 or 5, then if we bring it down by supplements of thyroid hormone, we might be able to successfully prevent miscarriage. And it seems that some women, if they make antibodies to their thyroid, make something known as thyroperoxidase antibody, well, it seems that those women have an increased incidence of miscarriage, increased by about 3.5 to 4-fold, an increased incidence of recurrent miscarriages by at least 2-fold. Now, whether, again, it's the antibody itself or just those women tend to be more hyper-selective, can't say. But we do know that there is the association. And with polycystic ovary disease, too, polycystic ovary syndrome, PCOS, the incidence of recurrent miscarriage is somewhere around 8 to 10%. Possibly it's due to the obesity, possibly it's due to the androgen excess, maybe the insulin excess. It's been said that, at least in non-pregnant women, well, you could treat them successfully with maybe some metformin. Metformin seems to be good for everything these days. Well, probably hasn't been shown to be really effective in pregnancy. And as a matter of fact, the question is whether the drug is even safe for pregnancy, so that in 2007, the Royal College of Obstetricians and Gynecologists in the United Kingdom and England, they said, recommend against using the medicine. And then, as far as the genetic abnormalities go, we have some problems that might be associated with sperm production. So there's a correlation of low sperm quality and increased sperm DNA fragmentation, where we have single-stranded or double-stranded breaks in the DNA. That certainly can be an issue. So now we have an issue where we can lose the pregnancy prior to the time when it implants in the womb, in the uterus. That's extraordinarily common. But then sometimes the thought is now that maybe the problem with an increased incidence of miscarriages is that some of the abnormal fertilized eggs, where there's a genetic abnormality, are let to implant in the uterus. That it might be that some of the decidual stromal cells that act as biosensors in the uterus aren't working properly, and they let impaired fertilized eggs start to grow until some other component of the body is able to recognize, hey, we got a significant issue here, and the body gets rid of the fertilized egg. So we have those two different kind of thoughts. The other is that maybe we have a genetic abnormality in the ability to make the HCG. The HCG is necessary for the pregnancy to continue, but there might be a genetic abnormality where it's not produced. There could be an epigenetic abnormality. We can confirm the pregnancy, typically with either the HCG elevation, or we can use an ultrasound examination. And actually, the ultrasound examination has simplified the diagnosis of pregnancy and miscarriage. The ultrasound really wasn't invented until the 1970s. We have the initial reports, at least as far as the medical use of ultrasound, in 1984, established the criteria for use in the 1990s, subsequently updated in 2012. Prior to the time we had the ultrasound, if a woman had an issue in early pregnancy, some bleeding, then she was hospitalized and tested serial over a course of several days. But now we do an ultrasound examination. We can also obviously make the diagnosis of miscarriage when a woman passes some of the products of conception. How do we treat miscarriage? Well, basically, we don't do anything. Nature is going to take care of itself, especially if it's prior to 12 weeks of gestation, and if the woman happens to be stable. Process can take a couple weeks to go through its entire cycle. Might even take 3 to 4 weeks to go through it. But 80% of the time or more, it's going to be successful if we don't do anything, other than maybe confirm it with ultrasound that all of the products have been expelled. Now, sometimes oral medicines are appropriate and are necessary. And the oral medicine, the availability of oral medicines, has decreased the need to use some sort of surgical intervention by about 70%. So if a woman has an incomplete abortion and soaks 2 maxi pads per hour for 2 consecutive hours, then we consider using a combination of medicines, some oral cytotec. Typically, it's used actually intravaginally, could be used orally, sublingually, but cause more diarrhea. And then oftentimes we precede the use of cytotec by about a day or so with some mifeprex. And the two working in combination, probably successful in about 95% of women who have the early miscarriage, to get rid of the need for surgical intervention. But if we do need surgical intervention, then in those women who have severe bleeding or severe anemia or cardiovascular disease, can be actually done in the office, D&C, or the vacuum aspiration, which is now used more commonly. sometimes added to a dose of doxycycline to reduce the likelihood of infection. Sometimes women get RhoGAM if the woman happens to be Rh negative, to prevent issues in subsequent pregnancies. If she happens to have a male consort who's Rh positive, then if she gets a shot of RhoGAM, that might be helpful. It's recommended in the United Kingdom that if the pregnancy has gone on for more than 12 weeks, or it's surgically ended or medically ended prior to 12 weeks, that women should get this RhoGAM. Some people say you should delay the attempts at the next pregnancy till you've had at least one period. If you happen to wait more period of time, it's probably unnecessary. If you wait at least one period till you've had one period, then that helps dating subsequent periods, or subsequent pregnancies rather. There's no evidence that there's really any reason that you have to wait. Doesn't alter the outcome of subsequent pregnancy. General recommendation is that if you've had a miscarriage for a week or two, probably avoid using some tampons, use pads instead. It's been said you shouldn't have sex for a week or two after a miscarriage to avoid infection, but that's not really data driven. We don't think you should use douches. You could start contraception pretty much at any time, including the IUD. If we have women who have recurrent miscarriages, then sometime it's appropriate to do some investigation, some immunologic investigation, checking with inflammatory reaction in the body, checking to make sure there's enough progesterone on board, checking to see if the uterus has some of those abnormalities I mentioned, or the woman has some of this lupus anticoagulant or the antiphospholipid antibody syndrome. Check the parent's chromosomes. Sometimes it's thought that if a woman has some of the early evidence of miscarriage, it might be appropriate to begin therapy with progesterone. Some people think that that's helpful. A review showed it might be just a little bit helpful. There's no clear-cut evidence that if a woman has elevated levels of homocysteine, that treating it with folic acid is really going to make much of a difference. There is evidence that if a woman has the antiphospholipid antibody syndrome, that the heparin that I mentioned before might be very helpful, either the unfractionated heparin or preferably the low molecular weight heparin, sometimes in combination with some aspirin. The idea about the IVIG, intravenous immunoglobulin, or the prednisone, that really remains to be fully investigated. But there are some interventions that are probably good if a woman wants to become pregnant. Probably maintain a healthy weight, avoid too much alcohol and tobacco and drugs. Proper nutrition seems to be appropriate. Avoid exposure to some of the agents that we know tend to cause miscarriage. We used to use bed rest and pelvic rest and vitamins and all sorts of different things. None of them have been proven to be effective. In the future, we're going to be able to test the woman's blood, and from the woman's blood, we're going to be able to measure the full DNA, the full genetic component of the fetus. That's really here, but it really hasn't yet diffused out where it's cost effective for the general community. But overall, hopefully, you've now learned something about miscarriage and put it in its proper perspective and maybe relieved some anxiety, because miscarriages occur considerably more frequently than most people realize, and unfortunately there's a lot of misunderstanding about the whole condition. Anyway, appreciate your watching. If you enjoyed the show, please subscribe, tell a friend. If you subscribe, you'll get notice as we post new shows. I appreciate your interest. I'm Dr. Ken Landau.